immunosuppressants? Presumably you start on a fairly high dose and then...
Yes, and I guess in general now we're using rather less immunosuppression than we did. I mean, again, most of the initial target levels were derived, well, we've got to give a bit more than kidney because we know we get more rejection than in a kidney transplant. Liver transplants, the liver is an organ where there's much less rejection. So if you look across organs, you'll tend to find that heart and lung patients are at this level, kidney at this level, and liver at this level. But we're rapidly coming down because we recognize that with lower levels you can still get out to 10 years, but you get out to 10 years with your kidneys working. And other things like very, very meticulous care of blood pressure early on is very important 10 years down the line. Control of lipids right at the beginning. So we've now learned, where at the beginning we were focusing very much on we must look after this lung within the body in the first year, we're now recognizing you've got to give equal weight to looking after the body around the lung in the first year, because we want people at 10 years to be fit and well and active, not alive but not fit, well and active, and with other complications. So those are the sort of change in strategy, if you like. And so we're tending to keep immunosuppression down. And of course there are other immunosuppressive drugs coming along, and there are other drugs out there, we mentioned azithromycin, that appear to be helpful in transplantation, but aren't specifically immunosuppressive drugs. Statins, which many of you will be familiar with, are probably a good thing to be on post-transplant. They probably have beneficial effects post-transplant and effects over just controlling lipids after a transplant.
Can you recommend me taking the other immunosuppression drugs? Because I somehow know from my doctors that when you take epamazine together with tacrolimus,
Yeah.
for example, it's a bit dangerous.
Yes.
It didn't damage the liver.
Well, erythromycin and clarithromycin, which are two classes of drug, macrolides, there is a big interaction. And we tell all of our patients, you must, wherever you go, you mustn't go on to erythromycin or clarithromycin without knowing about it. There has to be a very good reason to be on that drug, and you certainly want to reduce the immunosuppressive drugs because there is an interaction, and the interaction is mainly again on the kidney. It potentiates or increases the adverse effect of those drugs on kidney function. But azithromycin, which is the same class of drug but different, slightly different structure, has different properties. First of all, we use it in very low dose, only every other day, 3 days a week generally, 250 milligrams low dose once a day. And the interaction is so little that it's safe to use it. And obviously we know, it sounds very pompous, we know what we're doing. We're not just scribbling out a prescription, say, bye-bye, see you in a month. We're keeping an eye on what's happening. So whilst you're absolutely right, and there's a good general point, any patient following a transplant who's given a drug by a GP or someone who's not specifically involved in transplantation should always ask the question, is there a potential interaction between the drugs and what you're going to give me? That's a very good question to ask.
The thing is, I want tacrolimus and MMF, and my doctor wants to introduce small dose of sirolimus.
Yes?
But I was a bit afraid because...
No, I think as long as you reduce the tacrolimus, then there's not so much data with tacrolimus, but with cyclosporine, undoubtedly adding sirolimus can potentiate kidney issues. Okay. So, as long as things are being done in the right way, there's no reason why you can't partner sirolimus with the other immunosuppressive drugs. It just needs to be watched.
When you talk about the pleural deficits, if it's just with the interpleural space, presumably it's not a problem with getting that kind of lung out, it's just if it's against the rib cage. Is that what you're talking about? Well,
no, when you do pleurodesis, you obliterate the pleura. The pleura those two fine membranes for which, if you glue them together by whatever means, you can't get that lung out without a lot of root strength.
I thought there were two types.
There are different forms of doing a pleurodesis. You can use chemical means, which tends to stick, but it's not super glue. Talc is super glue, and a pleurectomy, where you remove, is super glue. So if you actually remove the pleura and allow the raw surface of the lung to stick up against the chest wall, because you remove that, that's super glue. That's, you know.
That's what I thought. I thought it was just the one against the chest wall.
I'm not there doing the chipping out, but I can assure you that a talc pleurodesis does cause our surgeons some time. They know they're in for a long night. The chemical ones are proportionately less of a problem because the bonding, if you like, the scar tissue that forms is not quite as dense as you get in the other forms. But the good news is that, okay, it makes life a bit more difficult, and it makes the operation a bit longer, but it doesn't mean you can't have one. And that's, I think, a huge issue because of the prevalence of pneumothorax in advanced disease in this condition. Then it's reassuring to know that you can't have best treatment for that pneumothorax because you might need a transplant, which has always been a problem. It's the same in the cystic fibrosis population. There's a period when specialists were worried about doing the right treatment to stick the lung up. And now there's, if anybody rings me up, I'm absolutely one of the physicians from outside, look, can you do a pleurodesis? Yes, get on with it. It's much more important to have a pleurodesis and get that control than sit for months with a chest drain bubbling away.
Would you ever consider doing live donor?
Well, we did for a very short period, and we've rather stopped that. In the United States, where particularly in Los Angeles, where there were quite a lot done, that activity has stopped, largely relating to the outcomes were okay but no better, and then there were one or two complications in the live donors. More complications than one gets with living kidney or living liver or even partial living liver.
Is that just because living lung lungs?
Yeah, you didn't actually remove the whole lung, you would remove a lobe, but some patients had problems, or some donors, with persistent air leaks and other complications following that. So really it's only in Japan now, and the surgery is very tricky. It's much trickier than doing the whole lung. So really, I think none of the centres in the UK now have an active living-related program. And to be honest, our efforts in upping the numbers of lungs through other means, as I sort of briefly described, I think is a much more, that's where our efforts should go. And there's no reason by doing that we shouldn't be able to increase the numbers done rather than have to go down that pathway of living-related. In Japan, they've got a program that's pretty good because that's the only organs they can only use organs that way. But most that's in the decision that's been taken in the UK is in line with pretty well the rest of Europe and the US. So we're not just kind of stepping out of line now.